All right. Shall we start now? Good morning. Shall we start?
Yes, I think it's about 5 minutes now.
Yeah,
so.
okay. Let me start. Sorry about that. Okay. So, so today we're going to talk about the scoring criteria and the significance of the hemodynamic significance. So why we are thinking, why do we need the scoring criteria at all? And what is the significance of this hemodynamic significance? This is PDA is our bread and butter for neonatologists. There is variability in practice in terms of region, temporal variation, as well as variation in the practice over time. So let's have a discussions on how we can improve and make our practice better. So in terms of disclaimer, no conflict of interest, a lot of anonymized images of echocardiographies. Today in my presentation today, we'll try and define hemodynamic significance of PDA. We will talk about the scoring criteria. Sorry, I just have to mute this stuff. Okay, scoring criteria to aid assessment and inform our treatment. My slides doesn't move, and of course we'll try not to talk about treatment. So let's start a case discussion. So we comes across, this is a very known thing which we deal day in and out. 23-year-old weaker who's day 4, ventilated, 500 grams, has a grade 4 IVH on the left, grade 2 on the right. And as a neonatologist, special interest in neonatal hemodynamics, you ask by your colleague to scan the baby. You come and scan, and this is what you find. Probably that there is a large duct. You can see the classical ductal view. You then do flow across the duct, and you do your LA ratios. And different people would do different ways, different measurements, and then you define the problem. And this is the most common report which people has been doing over the years in terms of quantifying the ductal volume, in terms of you give the size of a duct, you measure the duct, you see the pattern of the flow, you measure the flow in the systole, maximum flow in the systole, maximum flow in the diastole, you do some ratios of systole and diastolic ratios, and then you do a LAO ratios. This is what the convention is, and this is what most of us would do at some stage. And then we feedback it to our colleagues, or we inform ourselves, what do you want to do? Does it matter? Is this high likelihood of that this duct will remain open or present with adverse hemodynamic effects? We try and answer that question. We then can we quantify the hemodynamic effect of this duct using echographic parameters and the objective assessment? We don't know that. And do we consider clinical risk factors for morbidity and mortality? This is the questions we ask ourselves. And the final billionaire question is it worth eliminating it? Are you going to treat it? And then if treatment, how are you going to treat? This is day in and out questions which we have ourselves when we do a ductal study and share it with our colleagues. Now, we know that this PDA treatment is, it is a variation in the practice in different parts of the world, and has changed over the time from it being considered as an innocent bystander and to not to treat anyone, to it being a root cause of all evil and to treat everyone. And somewhere in the middle, we have taken the middle path where we identify significant ducts or asymptomatic or pre-symptomatic, where we start treating them or treat them when they're hemodynamic significant. So either we identify them before they become significant, or we treat them when they're significant. So this is what our practice is. And we know that in terms of what we know in terms of treatment is, the reason we start treating is the first ever published trial in 1978, where the patient were randomized either to PDA ligation or medical management, did show improvement in terms of ventilation as well as future improvement. So since then, we took this journey on, and we started treating ducts, and there's been many RCTs since then treating ducts. Unfortunately, none of them has shown any significant improvement in the outcomes of these babies. And we all know about this most talked about topical RCTs, which done recently over the last 5 years, includes Benedict's Baby Oscar, Tricopi, and the PDA RCT by Alcofash in 2021. So, but none of them had showed any difference in the outcomes. So here, after 80s RCTs, we don't have any large evidence to show that the PDA elimination of PDA cause change in difference. One thing to consider is the first RCT we ever had was actually the duct was actually eliminated from there. So, and we know that the duct closes by itself. It is what is the need to close itself? So most of the duct will remodel itself. The PDA will remodel due to pulmonary vasculature remodeling and close itself. So is there a need? The biggest study to see the temporal progress of this duct is by Militant 2015 published, shows that in babies who are 26 to 30 weeks of gestation, you see 50% of the duct will close around about 20-25 days. So that's what the medium gestation age will close. However, we know that in what we found is in extreme preterm, less than 26 of gestation, the median age of 50% of the closure is as high as 72 days. Actually, that's quite high. And one paper published in 2015 has shown that each week of symptomatic moderate large PD exposure to babies add your risk of BPD. So that's again, we know that these babies are going to have the add risk of BPD is there. However, none of the RCTs has shown that the presence of PDA does cause significant problems. But what we know is strong associations that we know about the reperfusion injury. So in babies causing intraventricular hemorrhage, various observational studies have shown that. We know PDA does cause pulmonary hemorrhage. We know PDA's association with BPD and mortality has been there. And what happens when you stop treatment, like from the Canadian experience as well as from the American experiences, we have seen that though there's not much difference in babies more than 26 of gestation in terms of BPD and mortality, what we've seen babies in the cohort of babies where they've stopped treatment, the babies who were less than 26 of gestation, they had significant increase in their BPD and mortality. So when we stop treatment, we particularly in babies less than 26 of gestation, we do get in trouble, and we have seen strong associations with them. So have we done our trials properly? Akif has presented several papers where we have questioned the trial methodology, and he has presented various, in his conferences, about the need for a better trial definitions. So we know that the failure of all this randomized controlled trial of pre-symptomatic PDA treatment to yield an improvement in short and long-term PDA morbidities result in recent emphasis to develop a better definition of PD hemodynamic significance. Definitely, we need to define our PDAs better if we want to identify them properly and to treat this properly. And what we have done is we have most of these trials or most of those treatments we have done in the past is mostly rely on PDA diameter, and we have basically oversimplified our problems rather than concentrating on the shunt volume. So do we have a consensus after this 60 years of treating these ducts so far? So we don't have a consensus at this moment. There are several challenges to get a consensus. I don't know whether it is possible to get a consensus at this moment. A variety of definition for hemodynamic significance have been used, which incorporate various clinical and echocardiographic variables, but however, most of them are not validated properly. And the cutoffs which are used on this echocardiographic PDAs are assigned significance are often located based on whether infants receive treatment or not, and the short-term outcomes rather than their long-term, morbidities. So not many trials have tried and identified these cutoffs for echocardiographic parameters properly. So when we're trying to define this PDA, what parameters are we going to consider? We are going to consider number one, shunt volume. We're going to consider heart adoptions, and we're going to consider gestation and status. And we know that shunt volume is the biggest, I would say, factor when we are trying to define the problem. And the thing to understand from here is the shunt volume is not as straightforward as we think. It's not, a shunt volume depends on few parameters. Number one, we talked about is the pressure gradient. So when we talk about P stands for pressure, so it's based on Poiseuille's law. So in terms of physics, Poiseuille's law define the measure that the flow depends on pressure gradient, the radius of the vessel, which is directly proportional to and inversely proportional to the viscosity of fluid and the length of the vessel. So when we talk about pressure gradient, we talk about the pressure difference between the systemic as well as the pulmonary vasculature. So what is the differences? And so the flow would depend on the pressure gradient. So it's not only as straightforward as depend on the ductal diameter or the length. And we can modify this pressure gradient by various strategies, ventilation strategies. We're not going to discuss that in details over here. That's beyond the scope at the moment. It depends on the ductal diameter. We know that, and we'll talk about that later on. Can we measure them accurately? It's of course depends on ductal diameter. It depends on ductal length. Inversely proportional ductal, longer the length, less the flow would be. Can we measure that properly? I don't think so. And the viscosity of fluid is very important. It's inversely proportional to fluid. So means if there is anemia, you will exacerbate the flow. So this is just to give a perspective that the shunt volume is a measurable volume, measurable quantity. But how do we measure it, and what is dependent on? It depends on various variables. And at the moment, we are measuring those variables and trying to define the shunt volumes, and those variables itself has a lot of fallacy in measurement. So are we able to quantify the shunt volume properly? And we know that when we are defining the significance of the PDA, we want to define the significance of the shunt volume. Now, when the shunt volume we're trying to define, we talked about the flow across the shunt, which will then depend on the various variables governed by the Poiseuille's law, and the impact of the shunt volume on the pulmonary circulation as well as systemic hypoperfusion. Of course, it will cause high pulmonary hypoperfusion, so more blood flowing in the pulmonary circulation at the cost of blood flowing out of the systemic circulations. But if we cannot measure the shunt volume directly, we can measure those outcomes from the shunt volume. So we can measure relatively, I would say confidently, pulmonary hypoperfusion by using various variables, and we can measure systemic hypoperfusion using various variables. This is what we think. And then the impact on the heart. It is very, very important that we know that preterm heart is different from a term myofibril. They have got disorganized fibers, they have fibrose, they have scanty beta-1 receptors, and they're dispersed myocardium. All this heart probably relatively are in a diastolic failure. They have a shorter diastole. They cannot increase the diastole phase that well, and most of the flow in the diastole happens during the atrial contraction. So basically, if you scan my heart and we do a mitral valve flow, which we'll discuss later on, most of the flow will happen in the diastole in the early relaxation phase, but in preterm babies, most of the diastole phase flow will happen not passively, but by active contraction of the atrium. That means the preterm babies are in a bit of a diastolic failure. And having a PDA, significant PDA on the heart would have a significant impact. Just understand that can have a significant impact on the heart and can tip it over. And again, various papers published shown that the relevance of diastolic function has a significant impact on these babies to have pulmonary hemorrhage as well as BPD later on. One of them is, which again, this study just show that babies who have got diastolic function has significant high incidence of pulmonary hemorrhage. Again, study done by Akif, this show that they have a significant incidence of BPD, which we'll discuss later on. And in terms of other variables, which also discuss that these babies who had high risk of BPDs itself at a higher risk of problems when they're exposed to duct for a prolonged period of time. And the preterm babies, which have shown that where the PDA, the median age of gestation for PDA closure is about 70 days, they are much more risk of having BPDs and mortality. And if they have other risk factors like not having steroids, if they are IUGR, if they have birth asphyxia, if they have sepsis, the risk increases. So these are the risk factors which itself contribute to BPD. And when they're combined with a significant duct, it does make it worse. So when we are treating duct, this should be considered as well. And we know that the PDA is a continuum from it being physiological, doing nothing, closing itself, to being protective when we have PPHN, to being pathological, causing significant volume overload, pulmonary overcirculation, systemic hypoperfusion, and then diastolic dysfunction. So when we are defining ecodynamic determinants in PDA, we talked about shunt volume. We know that the shunt volume itself and the heart adoptions, and the shunt volume itself is difficult to measure with size, with various issues, but we can measure volume overload and pulmonary overflow and systemic hypoperfusion. And again, to mention heart adoptions, we do measure, we should consider whenever we are trying to hemodynamically defining a duct, we should measure the function and rule out whether there is a diastolic function. Most particularly, as I mentioned earlier, that if you are in diastolic dysfunction, you are in trouble. Now, main topic we are discussing today is the how do we try and hemodynamically define PDA based on echocardiographic parameters, and how do we quantify them with a severity score, and what are the severity scores, and we'll try and appraise the severity scores. I don't know the answer to a lot of questions myself, but we are here to discuss and how we can improve our practice and see how people use the severity scores. Just a bit of history to make it interesting is that the M mode was the first echocardiographic determinant which the neonatologists started using, because before the 2D echoes did develop, that was the most common. The whole scans used to be done on M mode, and we started using LAO ratio. So M mode, LAO ratio is as old as 1970s, is still ingrained in our sidekick. And I'm no doubt that when you do a scan, your colleague would ask you what was the LAO ratio, and they would try and define the significance of duct based on this LAO ratio. And then the second factor or determinant which came in 1980s was ductal diameter, because when the 2D echo came, and all our findings and echo reports start basing on these two numbers. One was the size of the duct as well as LA ratios. However, lately we have started doing more and more echoes. We have a new breed of neonatologists like us who meets every Friday, and we discuss various ways and defining the shunt volume. And we have come with various echocardiographic determinants and parameters there. And there are more and more research work happening on these happening currently and in future. I think so. These are the way forward. How do we define this significance? So when we try and define the duct with such duct size and flow, things we use as a size, the flow pattern, the transductal peak systolic velocity, and the transductal diastolic velocity, and the ratio of systolic and diastolic velocity. And this is the most common practice. So PDA size, when we measure, we have a classical PDA view where we have a 3-vessel view. We identify your RPA, LPA, and the duct, and we measure the duct. Generally, as a convention, I try and put an ECG lead, and I always measure just to minimize the interobservability. And as a convention, I do all the measurements on end systole. So I do the measurement on end systole, take a frame, because with the frame, the velocity would change, and measure at the same time the LPA size. So my best practice is to, the narrowest PDA diameter should be measured using 2D methods only. At the pulmonary end, we should not use color. Measuring any blood vessels on a color, I would say, is that will lead into overestimation, and that's it's not a great practice to do that. So should never use color when you're measuring a duct vessel, and I'm sure most of us do that. Though we don't have, the ductal size would vary in different babies, the gestation age and birth weight. We don't have a Z scores for that, but we have Z scores for LPA. And if there is no evidence, if your Z scores are acceptable, I think so what you should do is Z score your LPA and compare the size of the duct with your LPA. That is against a decent idea where your duct is. And then we define the cutoff of significance. Do we have evidence for that? Study published in 2013 by Selmer first defined that a ductal size of more than 1.5 millimeter is considered to be significant and was associated with BPD, hemorrhage, and mortality and morbidity. So we have started using this convention that duct size more than 1.5 millimeter is significant. And we should consider that in terms of sensitivity and specificity. And then in terms of comparing with the LPA diameter, again, there's one study which I found had shown us where they have looked into when you're comparing LPA with PDA, and normally your whatever your LPA size should be, your PDA, if it's less than half of LPA size, then it's not significant. Basically, if it is similar to LPA size or more than LPA size, then you can say that it's a large duct, basically from the size point of view. However, how reliable are the measurements? Are we able to reliably measure this duct size? Basically, thing to remember is the duct comes in various sizes and shapes. You can have a straight through type of duct, you can have a watering can type of duct, you can have a serpentine type of duct, your funnel type of duct. And you have a 3D image. And what you're trying to do is, on a 3D image, when you're trying to do a 2D slice, depends where you're going to cut. Same duct, when you cut it different ways, different slice, you will measure it differently. So, depends on where your slice is. So this duct, suppose, is a funnel shaped duct, which I cut over here, I'll measure 1 millimeter. If I cut it over here, I'll measure 3 millimeter. If I cut it over here, I'll measure differently. Same duct over here, if I measure at different size, cut a different size. It's not possible for you on a 3D image, when you're trying to do on a 3D structure, when you're trying to cut a 2D size with various shapes, unless it was circular, thing would have been different. But depends on what the type of duct you have, and you will end up in cutting in different slices. So practically, if you see, theoretically, there is a problem there. It's not reliable measurement. And the gold standard for vessel size is a cat. And there's one study which has done, which shows that actually when you compare your ductal size on a cat as well as to the echo, there is no correlation with that. To an extent, Akif, in his paper, which he published to quantify a severity score, showed, and when he compared the severity score with the incidence of CLD, he showed that that ductal size had the poorest correlation. He goes and say that treating a duct based on a ductal size is like flipping a coin. You should basically not even consider that. It goes to a stage saying that. So we know that there are challenges with the ductal size. Of course, we still have ductal size. We still do the ductal size. I'm not saying that to stop measuring. I still measure it, but we need to know that it has got a lot of caveats to it. And just trying to define a problem based on ductal size might not lead to a proper definition of problem, and might not do justice to the problem itself. In terms of the pattern, we in terms of shunt flow, we see the pattern. We mentioned earlier, we see the peak velocity in systole and the diastolic velocity, and then we measure the flow. Again, Shepard and Nouri has defined the flow pattern is various types. There are like 5 types of pattern which are most common. One is the pure right to left flow pattern. When we see this flow pattern, we sometimes worry it is a duct dependent lesion, or maybe has severe PPHN. We leave this duct alone. This is a baby need to be further echoing to rule out congenital heart disease, or severe PPHN. Then the second most common pattern is a bidirectional pattern, which can be early neonatal pattern. When we see it is both right and left, left to right shunt as well as right to left shunt. And then at this stage, we think that maybe PPHN or maybe early neonatal period, and we don't bother this duct, we leave it alone. The third pattern which we see most commonly is the growing pattern, where we see mostly left to right. I would say 90% of them are most left to right, only 10% are right to left. Patrick McMurray in his AWARE scoring does mention that these are the babies which you should be considering treatment, if at all there are other parameters are there. And then the most common parameter which we see is the pulsatile pattern. When we see this pattern, we quantify ourselves in our brain. Subjectively start thinking, okay, this is a shunt which though I've not objectively quantified it, but this is a shunt which is significant. It's complete to right with a significant difference in the systolic and diastolic velocity. We measure this velocity in systole, we measure the velocity in diastole, and then we come out with a ratio. And then with the ratio, I'll come to that later on. And when we have numbers more than 4 or 2, we think it's significant and we start treating it. and we think this is a high volume shunt. And then we have a closing pattern where you have complete left to right flow with minimal difference between systole and diastole. The only thing I want to mention over here is sometimes in this closing pattern, because the diastolic tail is so small and the duct is closing, you might sometimes appear like a pulsatile pattern because there's a drop off. These are because the drop off, the duct is small, you don't pick up the diastole flow. That's what it is. So in terms of flow velocity, is that evidence to show that significant? Again, paper published in terms of severity score did show that babies with low velocity flows have high incidence of CLD and death. So this is an important parameter, and I think so we should consider that if you have a low velocity flow in systole of less than 1.5, you should think in terms of a large shunt volume. And when we measure transductal systolic to diastolic velocity flow, I don't think so there are much evidence in terms of objectively relating it to CLD and death, but we know that it hint towards a pulsatile flow, unrestricted flow, which again equates into a high shunt volume. And we should consider when the ratios are more than 4, then it's considered as a large volume, and when it's 2 to 4 is a moderate, and if it's a difference is less than 2, then it is a small volume. Now, volume overload, we all do that, and as we know historically, this is the first echographic incidence index you used to define a duct, and a cutoff of 1.4 was used as a marker of hemodynamic significant PDA in most of the studies. In terms of measuring, we take a parasternal long axis view, we measure and then cut an M mode properly, and again, as a measurement, I would advise you measure at a place where you would see you've cut at where the aortic valves is hinged, and you do an end systolic measurements. And you should, for LA, you should measure the maximum width of LA. In terms of LA area itself, one thing to keep in mind is that it is not specific to PDA. You can have increased, you can have so LA is nothing but a dilated LA ratio tells you about a dilated left atrium, and you can increase LA ratio by various cardiac problems like volume overload or mitral valve dysfunctions, diastolic dysfunction, all will lead into your increased volume overload. Also to consider is sometimes even when you have a very large duct, you might not have a large LA because you have a large PFO, and this PFO will act as a left to right flow actually for you to remember. So we know that we're trying to measure the volume overload. We know that in a part of a shunt, whenever there is a shunt, whether it's a VSD, ASD, PDA, the chamber of the heart which receives the blood first will dilate first. So it's natural that the LA is the first chamber which receives the blood from the duct. It's going to dilate, but sometimes it's difficult we need to ensure that you don't have to objectively quantified rule that there's not a big PFO when you have a small LA ratio, and when the large LA ratio, make sure you don't have a diastolic dysfunctions. And most common practice we think is that if you have a large LA ratio more than 2, we think it's a duct is significant, and it can be a problem. In terms of the other parameters, objective parameters in terms of looking into volume overload is LV volume. So first the LA start dilating, then the LV start dilating, and when the LV start dilating significantly, you start seeing a mitral valve regurgitations. And when you see mitral valve regurgitations, quantifying the mitral regurgitation based on velocity itself might be not justified, because it also depends on your contraction of the LV. So, but if you what I quantify is that if you have a mitral valve regurgitation, then you have a features of what left LV overload. One thing which I would significantly believe is that, and which has been shown has a significant substantiation in terms of shunt volume is pulmonary overflow. And there's various ways of measuring pulmonary overflow. One of them is cardiac output. And Jay did a presentation 2 weeks ago about cardiac output. So I'm not going to discuss in details, but cardiac output can be relatively measured, though again, it is not the gold standard. Measuring cardiac output from based on echo, again, but at least the trends are justifiable. The gold standard is still an MRI. We can see the left pulmonary artery and see the diastolic flow left pulmonary artery, and we can also see the pulmonary veins Doppler, ensuring that there is no evidence, no stenosis, to rule out the stenosis. So in terms of cardiac output, left ventricular cardiac output, we know that we do a parasternal long axis view, and we should measure it properly at the hinges of the aortic valve leaflets. Take a 5-chamber view, and then in a 5-chamber view, measure your LVOT, do a pulse wave of the LVOT, and you measure the velocity time integral by tracing the pulse wave Doppler. Most of the machines these days are smart enough. You don't need any calculation itself to do it. And if you trace it, then you should get a VTI. What I try myself is to do average over 3 consecutive waves. Never use an angle correction, because that will significantly give you different numbers as soon as you angle correct or you do. But most of the time, if you do 3 traces and choose the average of it, you'll get a decent number. Again, in terms of reliability of this measurements, this is the most, I would say, standardized or most reliable measurement in terms of shunt volume. Again, a key in this severity score study published recently did show that babies with cardiac output, high cardiac output, has high incidence of CLD and death. In terms of defining cardiac output, we think that more than 430 is a reliable cutoff and should be considered as high risk for BPD and CLD. We can also measure the right ventricular cardiac output in a similar way, and then try and do QP/QS ratios. In terms of pulmonary overflow, otherwise, we should, in terms of on a 3-vessel view, you identify your left pulmonary artery and do a diastolic flow velocity to the left pulmonary artery, and quantify them as small, moderate, and large, depending on your velocity flows. In terms of, sorry if I can get it there.
Bikash, Zoltan's here. Do you mean mean score or end diastolic on that slide?
And diastolic.
And diastolic, okay.
So basically, when you're doing a pulmonary artery, so so basically pulmonary artery flow should be pulsatile. So what you do is you have a pulsatile flow pattern. In the presence of duct, you start seeing a flow in the diastole also. Mm-hmm. Normally, if there's no duct, when you measure the pulmonary artery, should not have, this should come back to the base and should not have this diastolic tail. And if
I measure end diastolic in my practice, I was just wondering.
I would do the same.
For the number, what flow. You mean that when you talk about small, less than 0.3 end diastolic flow?
Yes.
Oh, okay.
That's what I do.
Okay.
In terms of pulmonary vein, you rule up that there's no pulmonary vein stenosis, and you do measure the, you can, when you do pulmonary vein, you have S, D, and A waves. You identify the D waves, and you measure the velocity in the D waves. And again, it's a surrogate marker of a pulmonary overflow rather than a direct marker, and depends on the pulmonary size and the ventilation pressures, and so many other dependent variables are there. So in terms of its reliability, I don't think so. It's a reliable absolute indicator in relation with BPD and death, and so most of the scores don't use them, integrate them. And so we discussed about pulmonary, the pulmonary diastolic flow as well as the pulmonary venous flow. And other thing to measure again is other ways you can measure pulmonary aortic circulations are mitral valve inflow, and a detailed study I would advise, and that's what I do in practice, is to do a mitral valve inflow study, which includes tissue Doppler, which gives them indications of both of diastolic function as well as pulmonary overflow. So, and I'm sure various people do it in the various levels of interpreting it. So we should, so recommended is to do mitral E wave velocity, transmitral EA ratios, do a tissue Doppler, measure your E dash, and do a transmitral E and A dash machine. There's all the calculation for yourself. See whether there's a mitral valve, do an isometric relaxation time, and your A prime. Paper published by Weimel Lai, probably is a pioneer in echocardiographic, functional echocardiograph, and he's done various publications. His book is still considered as a Bible for echocardiography in structural heart disease, used by all the pediatric cardiologists across the world. He has published a study looking into the normatic echographic values for right and left ventricular function, extremely preterm infants. And I think so this is the most standardized values we have at this stage, where various numbers are there. And so in terms of measuring mitral valve inflow, as you mentioned, we all do that. You identify your 4-chamber view, make sure it's not a 5-chamber. You see your mitral valve inflow, always try and use an ECG lead. You do your E flow and A flow. You know that in preterm babies, they have inherent diastolic function. If you do an echo on me, I will have most of my velocity flowing during the E wave, which is a passive flow during ventricular relaxation, and least in A waves. But in preterm, it's normal to have it in, you have a reversal of the flow, but depends on how reverse the flow is. In terms of if you have a, so this is a normal ratio. Again, as I mentioned earlier, is in his paper, he has mentioned about variables at day 1 of life in preterm babies, and then day 3, and then again at term gestation numbers. So you can compare that numbers, whether you have evidence of overflow or not. But if you have high E wave flow, that means if you have too much of pulmonary overflow, then your E wave will start increasing more. So start getting normalized. But that normalization is because of overflow rather than anything else. So and the EA velocity start mimicking that of a adult or that of a term baby. So your EA velocity then start becoming like more than 1. And so that even signifies that there is a large volume flow. In terms of isometric relaxation time, this is, we know that the, so what is isometric relaxation time? So, and you can, it is measured, you can measure both on well as 2D as well as through pulse wave, as well as you can do on TDI. And it's a diastasis phase of the ventricle. So the ventricle, before it starts relaxing, this early phase of ventricular relaxation, before it starts filling in, it just relaxes. And if you have too much of flow, then the isometric relaxation time will start becoming narrower and narrower. So smaller isometric relaxation time means the flow is too much. The ventricle doesn't get time enough to relax. So the relaxation time becomes smaller because it has to fill more. So a smaller, large IVRT is an indication of volume overload. Again, at the same time, you do your A prime. When you tissue Doppler, I think so Neil has done a talk on your diastolic function. I'm not going to discuss in details diastolic function, but we can measure your A prime as well as your EA ratios. And again, they're significant measure of your diastolic function. So basically, if you have your EA ratios less than 0.6, that means your heart is failing. You get so more than 0.6 is normal in babies. Preterm babies is fine. If you have isometric relaxation time is also a sign of heart failure, diastolic dysfunction. If your isometric relaxation time start increasing and getting more than 70s, again, it's a type you can identify diastolic failure. LVA ratios has got a significant predictable value in predicting death, and CLDs as shown in one of the papers. So again, as recommended on severity scores, to consider LVAO ratios in quantifying your duct to and rule out your diastolic dysfunctions, and then LVEA ratios similarly. So while we are trying to quantify pulmonary overflow, I talked about various measurements in terms of mitral valve inflow, which includes E velocity, EA, regurgitation mitral valve, IVRT, LVA prime, and LVE and E prime. Systemic hypoperfusion can be measured in various end organs, including your gut, which include your middle cerebral artery, your SMA as well as celiac artery, in your brain as anterior cerebral artery, middle cerebral artery, and in your descending aorta. And then, depends on what your flow is. If your antegrade flow, then it is considered as good. And if you have retrograde flow, then we start thinking whether there's a problem, and one of them, and various scores have used that in terms of your retrograde flow. You start scoring them in terms of and those are the babies which we sometimes identify. This is the babies which can compromise end organ, can result in NACs, can have end organ problems, can cause perfusion, reperfusion injury, can lead into IVHs, and so we start treating those babies. Though though the study done by Akif did not show any correlation of this with a CLD or death. So again, in summaries, these are the various parameters which we use to quantify a shunt volume, pulmonary overflow, and diastolic functions. Also mentioned to you is the clinical characteristic of babies. We should always consider population at risk and the babies who are at high risk of having your BPD. We mentioned about that babies who had less than 26 weeks of gestation are significant risk of BPD because they have higher risk of they're exposed to duct for a long period of time, and the median age of gestation of closure is much more longer. So in defining severity scoring of PDA, there's various attempts of defining them. A good severity score should be able to identify a high volume shunt reliably, should be able to identify population risk, and should have a measure of heart adaptation. In terms of the score, which was developed by Akif in 2015, which has been most quoted scoring system at the moment, he tried and define the shunt volumes with various parameters. He tried and define the cardiac adaptation and the clinical, and use various clinical variables. Of these 5 parameters have shown the maximum predictable values to predict CLD and death. So in terms of shunt volume, use PDA diameter, left ventricular cardiac output, and maximum PDA velocity. In terms of cardiac adaptations, which signifies your diastolic function, he's used LV A', and in clinical parameters, used gestational age. And when he defined them, he's come with an objective scoring or calculations, which you can create an actual sheet where it's various variables have been corrected. And this is how he has shown out of all the parameters, the PDA diameter was the least reliable measure. In terms of scoring criteria used by Patrick McMurray, he doesn't use the duct diameter at all. What he says is that he used duct diameter as only a screening. So and the flow as a screening. So if you have a ductal diameter more than 1.5 millimeter or predominantly left to right shunt, then you should identify, look for signs of volume overload. And if you have signs of volume overload, then you consider treatment. And he has given a scoring criteria for it. All the scoring criteria is trying to quantify the shunt volume. He's used mitral E valve, which we talked about it. He's used isovolumetric relaxation time, pulmonary veins, D wave velocity, LA ratios, and left ventricular output. Again, left ventricular output comes again and again wherever you go. And again, you give them a score 0, 1, and 2. And if you have a score more than 12, maximum score is 12, you score more than 6, then you should consider treatment. That signifies a high volume shunt. Based on the echocardiograph finding, you can either phenotype them as a small PDA with a low volume shunt, a PDA with a moderate high volume shunt, which needs treatment. Cardiac dysfunction, probably if you identify cardiac dysfunction, stay away from treatment. And you have to rethink in terms of how you follow this baby again and rescreen this baby. And if you have evidence of congenital heart disease, of course you're not going to treat. And then I have a protocol which we've all seen, how you have, once you phenotype the baby, how do you decide to go ahead with the treatment. So again, in terms of calculation, I've discussed this previously. I've developed a smart sheet, which I put in the data myself. I hope can open it, and does the calculation for myself, makes my life a bit easy in terms of what I can do with it. It does measure PVR, it does measure SVR, it does measure QPQS. All I need to put is the few numbers over here and does the calculation for me. Again, when we are writing a report, we should consider risk factors like gestation age, birth weight, and your try and define the problem in terms of shunt volume and your myocardial performance. In terms of echo study views, there's various papers published in terms of your study views. You should have a standardized views to minimize the interobservability and to give maximum credibility to your numbers. And just an example, this is how I do the views, and this is how we write our report. So I use this flow chart with me and put various numbers, circle them, and do a scoring system based on AVA protocol. And this is how I write my report in terms of where we are with the duct stratification. So in conclusion, we know that PD in the premature infant Life should be regarded as a continuum from physiological and potentially beneficial to being pathological. Not everybody needs treatment. There are several challenges in defining hemodynamic significance of the PDA. A variety of definition has been used with no clear validifications, to no clear justification of the validations. And when interpreting significance ducts, we should always consider the gestational age as well as vulnerability of the organs. So thank you. I'll unshare my screen over here.
Can I have a question? Because
yes, please. So I can't see any. Let me just have I unshared my screen, or is it still being shared?
but I mean, leave it on, please. Leave it on.
Okay, okay. Go on, please, Walter. I cannot see the hands.
Number one, absolutely very, very great presentation, honestly. Very well done, and congratulations. Would you be so kind to show me how you are writing the report, that not the Excel sheet, but what you're circling?
Can I can you see my slide?
Yeah, we still see your screen.
Okay, so I have to minimize this. Sorry, cannot. So take this out. So in terms of how I okay, so Zoltan, this is what I do. So these are the views which we talked about.
I don't see your slides. Didn't
you don't see my slides now?
Well, I see the final one, or your screen, but not the actual one.
Slide not moving?
Bikash, no. Try to unshare and share again.
Okay, resume share.
Can you see it now?
You can see now.
Yeah. So if you go to that one, which has that, you are just circling different parameters.
All right. Okay.
It was one or two.
This one.
This one. Yeah.
So this is what I have.
Yeah.
So what I do is I always use this. I identify them wherever it is. So I do the measurements. When I've done the measurements on my previous echoes, I try and, so what I've done in my practice over the last 3 years is that I ensure that I do rule out a diastolic dysfunction on these babies. And if they have a diastolic dysfunction, I start them instead of treating them, because I know it can be problematic. And I've seen that the diastolic dysfunction in my practice, though I don't have any, I'm still reviewing my, so over the last 2 years, I've been using the scoring system quite significantly. And I'm in a way of trying to get something out of it in terms of reviewing those numbers. But each and every baby I've screened in last 2 years I've scored them. And various parameters have.
So my question would be.
It finishes in 20 minutes. So when it started, it took me like half an hour, 40 minutes to start with. But now if you see, everything is done. So I don't do I do all my measurements once I'm off patient. So most of the measurement, if you see, are around the mitral valve inflow. And for mitral valve inflow, all you need to do is basically do a pulse wave and do a EA ratio, do a pulse wave. You've done a pulse wave shot, and you've done a TDI shot. And basically the measurement, you're doing a parallel long axis view. You've done your view there. You've measured your you can do all the measurement later on. And your 5-chamber view, you do your LVOT.
So you do the image acquisition quickly, and then you do.
As a practice, I don't try and spend. So most of them I finish it within 10 minutes, and I do all my numbers calculations after I've done the study. None of them on bedside. So I've done what I've done. Ensured that we've got ECG leads on place, so it helps me to identify those cardiac cycle properly, and then I do the scoring system. And I put them, and I've got a template for it. So in template, all I have to do is replace the numbers rather than anything else. So that even doesn't take long to write the report. We use a Badger EPR system. Yeah. Even writing report can be sorted in 4 to 5 minutes. So because if you start writing this report from beginning, it will take time. And time is a matter of essence when and so many PDAs you quantify them. But so by using this template, again, I have this on my desktop all the time. I see what the scoring is as a rough paper, and this is how I write the report. I mean, it's basically I've got a very standard performer of writing the report, and doesn't take me long. The impression I try and give is a shunt volume overload, pulmonary circulation, and cardiac function. always include cardiac function in my report to see what we're dealing with, which helps me in terms of making decisions.
I mean, it looks absolutely superb. And if you go back, why don't you record the A string, which was actually highlighted in Afif paper, that one of a pretty strong.
Oh, this is Iowa scoring, which I have done. This is the paper which used from Iowa, but I do AO scoring. I do LVAO.
Because you
problem
left
with
it out,
LVAO is LVAO doesn't help you to identify the volume overload. All it helps you to identify is whether you have, if LVAO is less than something number, then you know that you have a cardiac dysfunction. So all it's identifying is your cardiac dysfunction, diastolic dysfunction, rather than quantifying your shunt volume.
Okay.
So basically, few of the numbers in mitral valve inflow are significant predictors, like LVC, LV cardiac output and all. Do an IVRT does identify your high shunt volume. At the same time, there are other parameters which are used to define cardiac dysfunction, like your E prime as well as LV A prime.
And you measure the LVO in every baby.
Sorry?
You're measuring the LVO, the left ventricle output, in every baby.
Yeah, left cardiac output, I don't use it to define my cardiac dysfunction. All I use to define is your cardiac volume overload.
Oh, yeah, I'm just kind of trying to figure out that how much time it takes then if you were to do it with each and every baby. But you say it is doable with some practice, and especially if you do the calculations offline.
Nice to think what other people think, but for me, over the time, I have managed to finish it started with painful in terms of, took me a lot of time to do it when we started, but I thought I need to stop quantifying my shunt volumes just based on diameters as well as LA ratio, which are quite archaic and doesn't have much validity. So I started using shunt volumes, other parameters of pulmonary outflows, and it even finishes in 12-13 minutes now with the templates and everything in place. Within 15 minutes, I have, sometimes I've done the image acquisitions, done the measurements, and most of the machine does the measurement for you yourself. Sometimes, when you are, sometimes it might, depending on what you're measuring, when you don't have ECG, because we don't, if particularly extreme preterm 23-24 weekers, if there are no ECG measurements leads, then it might take a bit longer because we don't use ECG leads on them. But if you have ECG leads, the measurements, the machine does the calculations much more quicker and faster.
Okay, thanks.
Anne-Marie?
Sorry, I can't see. I'll stop sharing now then. In that case, stop share. So I can see people at least. Just talking to the screen, it's depressing. Yeah, go on, please.
Hi, Sandra here. Sorry, I'm having trouble getting access to the chat stream. That was an excellent talk, really lovely. Thoroughly enjoyed it. And I do something very similar to you with the detailed descriptive score for all the babies. And I would agree, it becomes easier with time as you do it more often. You get much slicker at it, and you do most of the analysis post-acquisition. I have two questions for you. One is, if you've got a large duct, but you've got evidence of diastolic dysfunction, atrial diastolic dysfunction, and to my mind, that makes those babies at much greater risk of pulmonary hemorrhage because it's a pulmonary venous hemorrhage, I think. Do you treat the duct, or do you do something to try and treat the diastolic dysfunction?
So again, these are the babies, as you rightly said, Anne-Marie, this is the highest risk baby. And we know the diastolic dysfunction pulmonary hemorrhage incidence is it's a direct correlation with that actually. And so what my practice, I treat the diastolic function first, start on a bit of dopamine, review the echo in 24 hours time, keep a close eye on the duct, and once diastolic function is treated, then I would start treating the baby actually. So, but the important thing at this stage is to treat the diastolic function before starting the treatment for the with Brufen.
And you're measuring.
This is what is recommended by. Sorry.
You're measuring the improvement just by measuring the A prime again.
No, I do the whole holistic as I mentioned in terms of diastolic. I do E prime, I do IVRT, and I do A prime. So I do all of it to measure the diastolic improvement. Basically, a lot of things is subjective. You can see the
Yeah.
heart, how
Yeah,
it
that's good.
reacts. But there's so
And
many
do you think-
parameters which are used objectively to measure the diastolic function.
And do you think you're seeing improvements of dobutamine?
I see. I mean, again, I have a baby now who was basically can present that case, interesting case, which somebody started ductal treatment. This baby, was improving minimum pressures to an extent that baby went into very high pressures. And I'll try and present that case at some stage. You can see that somebody was considering nitric oxide on this baby. I did an echo. And all you can see there is hardly any filling in the heart. Actually, the systolic function, it's a hyperdynamic LV, ejection fraction 95%. Basically, there's no filling happening in the heart. It's completely diastolic dysfunction. All it started with a bit of dopamine, and that changed the game. Babies, they need a nitrate and anything. You can see that there's hardly anything going in the pulmonary artery. It's a functional PPHN, basically. PVR, there is no forward flow in the pulmonary artery because of diastolic dysfunction.
Okay. And the other question was, do you find that your sort of descriptor score, the one you've got in white, amber and green, which I think is exactly how we use it, do you find that on day one, there's a mismatch between what you get on that and what you get in the severity scores, either the IO1 or FIFs? Yeah.
Exactly, Anne-Marie.
They're designed to be predictive. Yeah. Okay.
So day one, I completely, and probably as you measure more and more. So what Patrick McMurray has recommended is to do it within first 12 hours.
Yeah.
Scoring system, and this scoring system has a significant shift when you do it on day 1 to day 3 of life.
Yeah.
So on day 1 of life, it's so difficult just on base because you don't have that many features of volume overload, and all the score is mostly based on volume overload rather than anything else, and the volume overload features are not there. So just based on volume, I think so identifying a duct on day 1, I don't know of any reliable predictor which can predict your duct reliably forward looking, saying that this will be significant in the future.
So
day
would you
5, I think so we have got much better.
So I'm intrigued. Would you treat on the Iowa and AFIS scores on day 1, or would you say, yeah, I'm going to follow this one up closely and look at them again day 2 and day 3, and treat once you're established that you've got a big shunt?
In my practice, I only know one time when I've treated a duct on day 1 where there was clear indication of volume overload. Maybe started early volume overload features, and had high risk clinical factors like did not have steroids, did not have sodium nitrates. All the settings of CLD was there. So there were a lot of factors which made me start this baby on and I started paracetamol on this baby rather than anything else on day 1 of life.
That's interesting.
But most of them on day 3, day 5 is when we get the scoring and we start treating them.
Yeah, that's interesting. I started paracetamol on a day 1 baby yesterday, but I want to follow up closely and maybe change to something else if the pattern's established. Yeah.
But one thing I consider is the risk factors, like gestational risk factors and the other clinical risk factors, which I always keep in mind when I'm treating. Like more than 26 weeks, I've hardly treated them recently, but less than 26 weeks, particularly 23, 24 weekers is when I worry about these ducts.
Okay, lovely, thanks. Really enjoyed that.
Mahmood, sorry, your hand was up.
Yeah, thanks, Bikash. That's really a lovely talk. And as Anne-Marie said, we've been using similar score for probably a couple of years now. And that's my question regarding the diastolic dysfunction, because you can argue that actually a degree of this diastolic dysfunction is driven by the ductal flow from pulmonary over-circulation, and this blood is actually coming back to the LA, then the LV, and the LV cannot cope with it. So would you rather start treatment and that treatment will correct the dysfunction itself? Do you know what I mean?
I missed your question in terms of I didn't understand. So you think that the diastolic dysfunction is driven by pulmonary overflow?
Yeah. So if you have a degree of diastolic dysfunction of the LV, right, and that's driven by the increased ductal flow, which is shunting more blood to the lungs, and this blood is coming back to the LA, then the LV with volume overload symptoms and signs and echo parameters. Rather than correcting with dobutamine, my worry is that dopamine will just increase the systemic, reduce the systemic vascular resistance and might actually cause more shunting. So would you treat the duct and try to reduce the shunt volume, and that by that the LV dysfunction will improve by itself?
So the LV function. So Mahmood, thing to remember is that these babies have got inherent diastolic dysfunction anyway. So you need to recognize whether that is physiological diastolic dysfunction you're talking about, or is a pathological one. If we know that the volume overload of the heart does to the volume overload itself should not cause you diastolic dysfunction as such, but what will make is it will make the impact of diastolic dysfunction worse, because you don't have a forward flow happening, you have a diastolic dysfunction, and you have a back congestion happening. So basically, if you have a relatively preserved systolic function, it depends on what function you're happening. Is there a biventricular? Is it a global dysfunction you have, both systolic and diastolic, or you just have a relatively diastolic dysfunction? If you just have a relatively diastolic dysfunction, if it's physiological, then of course you think that is physiological. Most of the diastolic dysfunction does improve with time, and this is what most of the studies done by Wemelai and other parameters have shown, that there is the heart does mature relatively stable, and there is significant improvement in the diastolic dysfunction with the time. What I'm talking about is a pathological diastolic dysfunction where you have all the parameters and you see that. And those pathological dysfunction, I'm talking about much more than physiological one, which with your naked eyes doing scans over years and years, you know that this baby is in the trouble with the diastolic function. There is hardly any filling happening. And this babies, you will have a hyperdynamic LV. The heart beats like, there's nothing to push out. This heart is crying for blood. There's nothing coming in. And those babies, you need to relax the muscles. Those are the babies, because this will then exaggerate the impact of your PDA, will make it worse. These are the babies who has worse incidence of pulmonary hemorrhage and the worst incidence of probably BPD, as shown by Akif in the study.
Yeah, that's great. Thanks.
It's just the measurement. How do you measure them? Is and how comfortable are you in using various indices is important.
Thank you.
I've seen Jay asking about using Milrinone for diastolic dysfunction preterms. I generally don't use Milrinone myself in preterm babies. I'm not comfortable in terms of the because urine output clearance, urine output are decreased in preterms. We're not sure about urine output clearance and long-term problems. So I generally tend to use dobutamine rather than Milrinone myself. I don't know what other people use.
Yeah, I've used it a couple of times for catecholamine-resistant hypotension or dysfunction, if you like. But we start first dobutamine, and then if it's not responding, then I start only 0.2 and no loading dose, and just really observe very closely. And I had a couple of cases presented here before last year, respond really well with Milrinone, but it's not a standard practice.
Preterm babies, we should be just mindful in terms of Milrinone, I think so. Term babies, we use it more regularly, but preterm babies has to be very cautious. And I agree with that in terms of choice of patients where they are catecholamine resistant would be the better choice of patients.
Yeah.
So just in terms of, does anybody else use the scoring system? I know, Mahmood, you were saying that you use scoring regularly. And what's your experience in terms of your timing and as Zoltan was asking?
Yeah, I mean, like you and Anne-Marie already said, when you start first time, it just takes time because you're just getting your head around it. But once you do it more regularly, you know which view, what kind of parameters you're going to measure. For chamber, you're going to measure 1, 2, 3. In long axis, personal long axis 1, 2, 3, and then you just acquisition the image and process post after the study, and it takes probably around 20-25 minutes. But the whole study, obviously, if it is the first echo, you really need to make sure you're not missing any congenital heart disease. That what really takes time for me. But if there's a subsequent echo focused for duct only, then it takes much less time.
And actually, if you see, there are only few images you need to acquire. If you do the hemodynamic score, if you keep putting yourself, there are, like, as a measured in there are 8 or 9 pictures, views you need to acquire, and you can get the whole scoring.
And the reason, guys, you are using it is to standardize practice within the team, speak the same language, or for yourself because it's more professional, higher level, or both, or because the data is still, so Afif just started the study to see whether randomizing according to this is actually translated into improved outcome, isn't it? So it's a theory at the moment that if you treat those babies who are scored high in this developed scoring system, you will see a difference in the outcome. So I think it's still not RCT evidence-based in that sense. However, I think it does make a lot of sense, much better than just taking the LA over AO and treat.
So,
a fifth study, sorry, Bikash, a fifth study, I think it's out there since 2018, isn't it?
yeah, it's so it's published in 2015-16.
Yeah, but I mean, it
One
is
which was
a study to demonstrate that it is associated with these outcomes.
LDN.
RCTs, they just started it, isn't it? So it still remains to be demonstrated that using this indeed will improve your chronic lung disease rate if you start treating and randomizing babies according to this scoring system. However, I think it does make a lot of sense, and I think it is very close to my heart when I read it, to introduce it, although I felt that it will be a little bit too complicated. But I mean, if there are centers using it and you are happy and it wasn't that you started and half a year later you just dropped it, I think it is very reassuring.
So, Zoltan, what I do is I don't base my decision just on basis of scoring, but it gives me more information in terms of I'm trying to quantify the shunt volume. Basically, if I see lots of these circles in the high volume, because again, what we're trying to is quantify the shunt volume based on pulmonary overflow, right? And just not based on decisions on that archaic methods of LAAO and ductal diameter, which are not the best parameters. So at least we don't have anything at the moment. We need to base our decision on something, am I right? So instead of just subjectively saying something, I think so it just helps us to give you some objective parameters over here.
But I mean, I think it does make a lot of sense, and it's good to hear that there are centers who adopted it, and you would report it works well so far or has been working well. So it is not something that you tried and you dropped. So because then we might consider introducing it. I mean, Giza is on the call. Anyway, I will discuss this within my group, not my group, but my my hospital, and then we'll see. Okay.
Well, thank you.
Thanks very much
everyone for joining today.
Very helpful for me, honestly. Thanks very much for sharing this, and also
sorry guys, IT's been useless as well.
Sharing your experiences with this. Okay, will you upload this talk so I can?
I think so. Mahmood or Ahmad uploads them.
That's I will be uploaded. No worries.
Thank you. Thank you so much. Thank you.
Okay, excellent meeting again.
Yeah, Bikash, thank you very much. This really was something. Yeah, we'll upload the recording and see.
Thank you.
Yeah, thank you very much.
Bye.
Okay, bye-bye.